Hi everyone. Today we'll be studying a very important topic in obstetric emergencies and that is amniotic fluid embolism. बहुत important topic है. It's a catastrophic emergency for the mother, but इसको समझना थोड़ा tricky है. So give me 5 minutes and I'll explain you the whole topic. What is happening in amniotic fluid embolism? Basically, immediately after delivery or during the delivery, the uterine sinuses, the uterine veins are open. So all that placental vessels, all those uterine vessels which are providing blood to the baby, they are lying all open. And when the delivery happens, there is a negative pressure created, resulting in sucking of some of the amniotic fluid into the maternal blood. So those open uterine veins suck some of the amniotic fluid and transfer it to maternal blood. क्या ये normally कभी नहीं होता है? होता है. In normal pregnancy, during the delivery, some of the amniotic fluid, some of the fetal cells are sucked into maternal blood. But it does not give rise to amniotic fluid embolism. तो यहाँ ऐसा क्या special हो रहा है? Remember, it is the meconium-laden amniotic fluid that is being sucked. The meconium-laden amniotic fluid is being sucked into the uterine veins. And that lead to this emergency condition called as amniotic fluid embolism. So what is happening? When this meconium filled fluid is sucked into the uterine veins, it goes into the right side of heart and eventually reaches the lung. So the first side where it will create a reaction is basically the lungs. As the lungs perceive this foreign body, as they see these meconium particles, there is a response, there is an inflammatory response resulting in sudden pulmonary hypertension. So suddenly, जैसे ही lungs को ये meconium मिलता है fluid, suddenly the vessels constrict, resulting in transient. So it is not permanent but a transient pulmonary hypertension. अब जैसे ही ये pulmonary hypertension होता है, what happens? The right side of the heart, which is pushing the blood to the lungs, that right side of the heart is now not able to push that blood. The afterload of the right side of the heart is increased. क्यों? क्योंकि जो vessels हैं, pulmonary vessels, they are constricted. So if I can make a heart here, this is the right side. Now it is not able to push this blood to the lungs, resulting in the blood getting filled in the right side. Something called as right-sided heart failure. So there is pulmonary hypertension resulting in right-sided heart failure. And since the blood is filled in the right atria and ventricle, there will be a septal deviation. There will be this septal deviation compromising now the left side. So अब left side compromise हो गई है because there is septal deviation. As a result, now the output of this left side is also reduced. So when the output of left side of the heart is reduced, it means, can I say the cardiac output is reduced? Can I say the blood pressure of the patient is gonna fall? And all these things, it started with lungs, with transient pulmonary hypertension, but resulting in right and left-sided heart failure will eventually also lead to pulmonary edema. Since the vessel pressure is so much and there is heart rate which is failing, it will lead to pulmonary edema. So what the patient will have? Patient will have a respiratory compromise. First thing. Second thing is patient's BP will fall and the cardiac output will be low. So there will be hemodynamic compromise. Third thing. And if the patient is able to survive these two, third thing happen. And that is this meconium fluid is circulating in maternal blood, resulting in something called as systemic inflammatory response syndrome, SIRS. This systemic inflammatory response syndrome result in severe endothelial injury And we know when endothelial injury happen, तो क्या होता है, छोटे छोटे प्लेटलेट्स प्लग बन जाते हैं. To cover those endothelial gaps, small platelet plugs are formed. And when so many platelet plugs are formed, we will eventually have consumptive coagulopathy. Or what I can say in simple language, DIC. That is the third thing. So it all started with pulmonary hypertension resulting in right and left-sided heart failure, in the end resulting in consumptive coagulopathy. All this because the meconium-laden amniotic fluid reached the maternal lung. So basically, it is a very much clinical diagnosis. There are no diagnostic tests for amniotic fluid embolism. It's a clinical diagnosis. It is a triad where there is respiratory compromise, there is hemodynamic compromise, means the BP is low, and then there is consumptive coagulopathy. All these things, when you find just immediately after delivery or within 30 minutes of delivery. So delivery or immediately within 30 minutes of delivery, when you find these three things, you make a diagnosis of amniotic fluid embolism. It's a clinical diagnosis. There is no investigative test for that. How can it differ from PPH? ये सब PPH में भी तो होगा. PPH maybe the BP will fall, patient will be gasping. But see, PPH में क्या sequence होता है? There is severe blood loss. First, there is severe blood loss. इतना blood loss हो जाता है that now the BP will fall. And since the BP will fall, patient will start gasping. Here, the sequence is reversed. Patient will start gasping first because there is pulmonary hypertension and edema. BP will fall. After that, you will see that now the patient has started bleeding profusely. Initially, patient doesn't bleed. The profuse bleeding is in last. That is because of DIC. This is the sequence. And that is how you can differentiate it from PPH. The risk factors on which I asked you the questions, anything which will increase the negative pressure, the sucking of the uterus. Some are general risk factors like old maternal age, post-dated pregnancy. Other than that, rapid labor, labor which commences within 3 hours, cesarean, difficult instrument delivery. All that will increase the risk of amniotic fluid embolism. But remember, uterine hypertonicity, uterine hyperactivity does not increase the risk of amniotic fluid embolism. Because when uterus is hypertonous, which is repeatedly contracting, the intrauterine pressure is high. And this high pressure closes the uterine veins. Instead of opening it, causing a negative pressure, it closes the uterine blood vessels. So if the uterine blood vessels are closed, there will be no sucking of the amniotic fluid. So uterine hypertonicity or uterine tachycardia, so uterine hypertonicity or uterine tachysystole is not a risk factor for amniotic fluid embolism. How are you going to treat? As such, you have to do everything in a very rapid fashion. It's an emergency condition. You can immediately lose the baby. So management is basically CPR. You have to give cardiac and respiratory support. Inotropes. So you have to give inotropes because the heart is not able to contract. There is contraction failure. The heart is not able to pump the blood. So you will start with inotropes. Also, you will need, for hypotension, you will need to give some vasopressors. What about IV fluids? Patient is hypotensive. Will you give IV fluids? No. Patient is not hypotensive क्योंकि उसने blood lose कर दिया है. Patient is hypotensive because the heart is not pumping the blood. Heart is already overloaded. Lungs already have edema. In that case, you will not give excess of fluid. Right? And last, you have to manage the bleeding and DIC by giving the coagulation factors. So remember this much about amniotic fluid embolism, that it is a triad present just after delivery or within 30 minutes of delivery, a triad of respiratory compromise, hemodynamic compromise, and later DIC, resulting in excessive bleeding from every site. Since it is sudden, it is clinical diagnosis, you don't have any investigation, and the management is very much depending on the inotropes, vasopressors, and cardiopulmonary resuscitation. That's all for the topic.